Sorry for this late start, but the technical difficulties were definitely on our end, not the Danish end, which is not too surprising given their excellence in IT in these areas. My name is Daniel Castro. I'm a senior analyst with the Information Technology and Innovation Foundation. For those of you that don't know ITIF is a non-profit, nonpartisan public policy think tank that works on a variety of issues related to IT and innovation. I'm really pleased to be here today to share with you the findings of this report that we're putting out, explaining international leadership on health IT. This is part of a series on IT application leadership that ITIF will be putting out over the next few months, identifying the leaders in different IT application areas and the lessons that other countries can learn from these leaders. For health IT, the news isn't very good for the United States. We're not doing too well, and I think most people in this room probably know that. It's unfortunate because health IT is really a critical part of healthcare reform. It's critical to improving care, it's critical to improving or reducing costs, it's critical to increasing access to services. The good news is that there's a lot that we can learn from the leaders. There's a lot that we can learn from countries like Denmark, Finland, and Sweden. So today, to share their experiences, we have a great panel put together. First, in person, we're very lucky to have Hannu Hanhijarvi, who's the Executive Director of the Healthcare Program at Sitra, the Finnish Innovation Fund. And then joining us online via Skype, we have Christina Wancher, who's the Chief Consultant at Medcom, the central organization in Denmark organizing health IT. And also Morten Petersen is joining her, who's the Managing Director of the National Danish eHealth Portal, which is really one of the most impressive displays of health IT by the Danes. So for today's presentation, what I want to talk to you about is three key questions from this report that we're releasing. The first is which countries are leading in health IT? Second, what factors have led to their success? And then of course the key question for the United States are what can the US learn from these global leaders? So starting off, what countries are leading in health IT? In this report we look at about 7 different metrics. I want to highlight 4 of the probably key metrics from the report. The first one is the use of electronic health records. Electronic health records are really the basic building block of health IT. It's what most other health IT applications are built upon. And it's a good way to see how countries are making progress. When you look at the use of electronic health records by primary care providers, you see that there's a number of countries that are already above 90%. You have countries like Norway, New Zealand, the UK, the Netherlands. All these countries are over 90% adoption. And then you have Denmark, Finland, and Sweden, which are basically at near universal levels of adoption. Sometimes there's a few stragglers, but for the most part they're at 98, 97, 99%. In contrast, when you look at the United States, we're only at about 28% adoption of electronic health records among primary care providers. And this number varies depending on who you count and how you measure this, what you consider an electronic health record. We also look at the use of electronic health records in hospitals. And this was really an interesting finding that we had in this report, and that's that the adoption of health IT, or specifically electronic health records, generally follows 2 separate trajectories. One for primary care providers, and then a second one that usually lags primary care providers for hospitals. And there's various reasons for this, but this is one way of really seeing which countries have not only succeeded with primary care, but they've also succeeded with hospitals. And in this regard, again, you can see that Denmark, Finland, and Sweden are well above average. In fact, they're some of the only ones that really have above 20 to 30% adoption. I just want to mention the number that you see for Denmark is around 35%. That's definitely lower than Finland, that's around 100%, and Sweden, that's around 3/4 of hospitals. But the number for Denmark was taken from 2006, so it's probably a little bit higher, and they do expect to get closer to 100 over the next few years. The third factor that we look at is this ability to order lab tests electronically. And this is, when you think about health IT, you can think about different generations of technology. So your first generation of technology is just the ability to collect data electronically. This is just capturing electronic data in a clinical setting. The second thing that you do, kind of health 2.0, is exchanging clinical data. And this is really becomes a much harder problem. You have to work on data standards, you have to have the right protocols in place to exchange data, you have to have the right infrastructure in place to do that. So the ability to order lab tests electronically is one good indicator of how successful countries are with kind of this Health 2.0, which also leads to Health 3.0, which is really where you want to get to, where you're using decision support tools to make healthcare better. So again, if you look at the metrics, you have Denmark doing quite well at 80%, Finland with over 3/4 of providers, primary care providers with access to laboratory information systems, and in Sweden we didn't have very specific data, but we were able to find out that it is very common, so we're expecting it to be at least above 50%. Again, in contrast, you see the United States is very low. We're only at 20% adoption in this area. The last metric that we look at in this area is e-prescribing. E-prescribing is really kind of the easy win for health IT. It doesn't necessarily need to involve, it could be a standalone system. It doesn't involve as much integration. So it's a lot easier to implement in doctor's offices. And you can see that this is the case partially from the fact that all three of these countries are already at 100%. And this isn't necessarily 100% for transmission of electronic prescriptions, but at least for their generation. When you look at the United States, again, it's only around 20% for generation of electronic prescriptions. And then the number is significantly lower, down to about 7% for actually transmitting the prescriptions. And of course, it doesn't include any numbers that might be for all the people to buy Viagra online in the United States. But the key question that we want to look at, of course, is what factors contribute to this? How do these countries succeed with health IT? And there's really a lot of factors that we look at in this report. They have various degrees of influence, and obviously some of them national leaders can influence more than others. Probably the largest factor that we see here is the national leadership. Every single country that is leading in health IT, Denmark, Finland, and Sweden, but also other countries that have very high rates of adoption of primary care providers using electronic health records. All of these countries have achieved this by not just having a national vision, not just having political leaders say, we want to adopt electronic records universally in our country, or we want to use health IT. They actually have specific strategies. They have specific organizations responsible for organizing the national response to this. It didn't just happen on its own. And this is really a key theme that you see in many of the factors that influence health IT adoption, because the challenge here is one of organization. The challenge isn't just, can you go out and buy the technology? Implementing health IT really involves coordinating various stakeholders that have competing interests, that they have divergent views, they don't always share the same goal, and bringing them together and getting them to work together. It's kind of the idea of getting everyone to row together, row upstream. That's a hard problem. So one way of getting over this is through national leadership. The second factor that I think probably jumps right out at you when you see what countries are leading is that all of these countries pretty much are using or have single-payer healthcare systems. And it's not a recommendation of ours that the United States has to move to a single-payer healthcare system, but you do see in these systems that the cost and benefits of investing in health IT are much better aligned. Government's already involved in healthcare, so it's a much easier proposition for government to say, we're involved in it, so do you mind if we try and do it better? You don't get as much resistance. You also see in some of these countries much more government involvement, of course, in the actual providing of care, either through primary care clinics or through hospitals. And again, this is kind of a management and organizational issue, where when the government's involved, the government's able to actually go in and make these changes more easily. The third factor that we look at is the use of incentives. You see this in many countries that use incentives. We see this even in the United States for e-prescribing, and of course with the Stimulus Act. The Netherlands is a great example of how stimulus has been, or how incentives, financial incentives, have been used to spur health IT adoption. In the Netherlands, IT investments made by doctors have been tax deductible for some time. Also, since 1991, all healthcare, all doctors that used IT systems in their practice received incentive payments, and this really paid off for the Netherlands. If you look back to 2002, the Netherlands had about 88% adoption of electronic health records in primary care providers. This was in 2002. I mean, if you think back to what we were doing in 2004, that was when we were just setting out our strategy in the Bush administration. The fourth factor that we look at is the use of mandates. You have the carrot approach and you have the stick approach. And Denmark's been great in the use of mandates, and I'll let our panelists talk more about that during their time. But another example of this is Norway. Norway has been able to achieve pretty much universal e-prescribing through using mandates. They've also shown that you don't have to mandate specific technology. You don't have to say you must have an electronic health record system in place. What you can do is you can also mandate specific functionality, because ultimately it's not about the technology. The technology is just a means. You have certain ends that you want to get to. So for example, in Norway, there's been a mandate for quite some time that doctors have to use, they have to maintain clinical records over large periods of time. As a result, they're one of the few countries that early on switched to paper-led offices. It just made sense. It was easier and more cost-effective to store records electronically because of this requirement. Another factor that we look at is the size of a country. On the one hand, when you talk about IT systems in general, a larger country or a larger population makes it easier to implement an IT system. For the most part, development costs are usually what's high. And it's easier to amortize that cost over a larger population. It makes the cost go down. But on the other hand, larger countries generally have more stakeholders, more diverse stakeholders, and when it's a coordination challenge, this really becomes a barrier to progress. So in small countries, it does make it easier to implement health IT because there's fewer players to coordinate. You also see some mid-sized countries, and the UK is the best example of this, that have also succeeded with implementing health IT. And in part, they were able to overcome the challenge of being a slightly larger country because they have such a centralized healthcare system. The NHS maintains 90% of the hospital beds in the country. So there's a lot more government control in that area. Another issue that we look at are other structural issues in the healthcare sector. And again, many of these tie back into this issue of coordination. For example, you can look at the number of vendors selling health IT in a country, and that influences issues such as interoperability. Fewer vendors usually means it's easier to drive adoption because providers have more of an incentive to buy a system. They buy the system and they know it's going to work. And you do see consolidation over time in many countries where the number of health IT vendors gradually decreases as adoption goes up. You also see other areas where you have competing stakeholders. So for example, pharmacies is a good example of this. In Sweden, Sweden had a national monopoly on the pharmacies. There was just one company. And so when Sweden decided they wanted to implement e-prescribing, it was very easy. They had many retail outlets, but there was only one organization that had to buy into this idea. As soon as the pharmacy said, we're going to do this, they were able to do it across the board. And they were also able to implement very good decision support tools into their pharmacy because it was just one system and they had all the data. A related factor is the average size of practices. You see this, especially in the United States, being a real barrier to progress. The larger practices are, again, you have a larger number of users, the costs go down. In the United States, over 2/3 of doctors are in small or solo practices in the United States. And then when you look at adoption rates in the United States, it really breaks down. Larger practices are around 46%, smaller practices are around 16% adoption of electronic health records. So that really becomes a barrier there as well. There's some societal and cultural factors that we see in a lot of these countries. When you think about Denmark, Finland, and Sweden, these countries are certainly leaders in not just health IT, but IT in general. They have very technologically savvy populations. They have high rates of computer ownership, broadband use. And this translates into patients with higher expectations for their doctors. You have more informed consumers. And this is something that we've seen in a number of countries where patients would kind of think, if I was going to a doctor that wasn't using electronic health records, wasn't using health IT, they're a second-rate doctor. So there was a real consumer demand for change. And you didn't just see that at the consumer level, you also saw that among doctors themselves. There was peer pressure for adoption in a lot of these countries. There was a competitive nature between different doctors to push for adoption. Privacy has been a big issue in the United States, and certainly privacy is an issue that every country is concerned about, protecting medical privacy for its populations. In most countries, what you see are strong privacy controls. You have audit logs, you have systems that are using encryption, using the latest technology, and what that means is that generally leads to good acceptance. When the technology works, people don't usually object to it. Sweden maintains a number of government-run databases that collects personally identifiable medical information. And they allow people to opt out if they want. There is that option. And it turns out that very few people opt out. It's around 2 to 3%. It's very low. And really the reason it works so well in these countries is because two reasons. One, they get the technology right. And two, there's a bigger recognition of the fact that moving towards health IT actually gives you more privacy protections. When we were talking to some of the people in the Netherlands, I believe we were told that people, right in the United States, you see people objecting to the use of health IT sometimes for privacy reasons. In the Netherlands, it was the opposite. They would say, why are you still having paper records? And the reason for that was there was a number of publicized incidents where paper records were disposed of in a dumpster. And people said, why is my information not protected? Why is it not locked up? So there's just a really different mentality in a lot of other countries. A major factor that we see in many of the countries leading in health IT is this use of common infrastructure, or shared technical infrastructure for health IT. And when you're implementing health IT, you see especially that you have a lot of doctors in various practices. They're all trying to do the same thing, especially when you have a good vision and a good strategy. So when you think about this, all the doctors are trying to answer the same questions. They're all saying, where can I store my records? How am I going to store this in an IT system? How am I going to authenticate healthcare workers? How am I going to identify the patients and match them to their records? How are we going to exchange data? Do we have a secure network platform on which to do this? So, the kind of common answer is, let's do this together. And you do see that in pretty much every country. Sweden has a national broadband network specifically for healthcare. And this has really acted as a platform to allow them to build up a number of telemedicine applications. It allows them to do video conferencing from pretty much any facility. In Denmark, I think probably the best example of a shared or common infrastructure that they've developed is the National Health Portal. It's not an infrastructure in the traditional sense, but it's a technology that's being used by pretty much every provider and patient. And by investing in this increases the value of any other doctor or anyone else that wants to invest in health IT, because it's something you can plug into and you can gain a lot of value from. And then Finland is doing a lot right now in this regard. Finland's investing, I think it was 20 million euros on building a centralized electronic archive and e-prescribing system, because again, these are tools that every country or every doctor in the country is going to want to use. In addition to having a technical infrastructure, you also have information infrastructure, or a common information infrastructure. You have standards that you want to have developed. And really the government role that we see in many of these countries, governments take a very active role in coordinating and expediting the development of standards. Sometimes through mandates, sometimes through consensus building activities, and you see a lot of collaboration and interaction with industry. It's not just government acting independently, it's really a collaboration, and this is one of the reasons why standards development, I think, has worked very well in these countries. And the last factor I want to mention here is unique patient identifiers. This is really a simple idea. It's the idea of course, using just a unique identifier, a unique number to identify every patient. Because you have many different databases, and when you want to link these people together, you need a way to do that. The United States, we're pretty much we're relying on statistical matching to try and achieve this. But when you look around the world, pretty much every country that's had even a little bit of success with health IT has all used unique patient identifiers. And in the United States, we actually were going to do this. This was included in the '96 HIPAA legislation, but because of, I think, what we have kind of a warped debate on privacy in some regards, that's been taken out and we haven't been able to do this. So this brings us to the big question, of course. What are the lessons that the United States and other countries can learn from the leaders in health IT? I don't think anyone will be surprised with the first recommendation. The biggest factor is national level leadership. And this is something that I think we've been lacking for a while. We're starting to get that in the new Obama administration. We need to continue this. We need a national strategy that has clear metrics, clear goalposts, and accountability. And that's what you see in a lot of these other countries. I think too much the United States approach has relied on this bottom-up strategy, and that's not a good way to coordinate so many competing stakeholders. The second recommendation that we have is to provide sufficient funding for health IT. Certainly the stimulus measure was a huge start in this regards. But there's a question of, is it enough? I'm sure some of you have seen a number of reports coming out questioning if the incentives are more than what providers would have to pay, or even the penalties are more than the cost of upgrading. If you look at the RAND report, which is probably the most well-known on the overall cost of adoption, the RAND report predicts the cost will be $8 billion per year over the next 15 years. So certainly the stimulus measure falls short of that. I'm not saying we necessarily need that amount, but this is something that should be part of a national strategy. So along with that, when we're developing the national strategy, we need to use incentives and we need to use mandates. This is what you see in a lot of countries where they say, you know, we're going to have incentives for a few years, but this is the cutoff year. This is the year we're going to have it. At that point, the mandate comes into place, and that's where you start enacting stronger penalties. We're also talking about funding not just health IT applications that we know work, you know, electronic health records. This is something that we should have today. This is old technology. We also need to be investing in the next generation health IT technology. We should be thinking about what are the hospital of the future going to look like? What is that going to look like? How can we use wireless technology? How can we use RFID? How can we use robotics to improve healthcare? Along with this, you know, the government is one of the biggest payers of healthcare, even in the United States, and we can continue to use the federal purse to drive changes in the marketplace. I was just made aware of, you know, the Social Security Administration has a proposal out right now to implement an electronic health record system in their various employee clinics. So when they're making these purchasing decisions, you can see that they are thinking in some ways about how electronic health records are changing things. They have part of the requirements is whatever system is implemented, it has to provide a patient interface. So we need to be thinking about other ways to drive adoption using federal spending. Our fourth recommendation is to build and share tools for health IT. Probably the best example of this in the United States to date is the Connect architecture that's part of the National Health Information Network. And that's been a very good program, but there's probably a lot of other areas where we can do this. You know, we need tools for identification of healthcare workers. We need a way to identify patients. And it doesn't have to be a government-provided solution. It can come from the private sector, it can come from public-private partnerships. But there is room for government to work and collaborate in this area. I haven't talked yet about health record data banks. We put out a report 2 years ago calling for health record data banks. When you think about the United States, we obviously have some unique political situations, unique political climates in some regards. There's a lot of resistance to anything that's government-run. The government-run brand isn't very popular right now. So when you talk about implementing electronic health records, and you see a lot of countries that have done centralized systems, and you think, you know what, it just will never fly probably in the United States. So what's a uniquely American solution that we can use? One idea is using health record data banks, which really changes the model from one where the provider is maintaining the health records to one where the patient chooses who provides, who maintains their electronic health records. It gives the patient ownership, and it really changes the dynamics between the dynamics and the financial incentives. It really creates a workable business model for implementing health records. Along with this, the use of personal health record systems is really a critical part of this idea of creating patient-centric healthcare. Patient-centric healthcare relies on empowering consumers, empowering patients to take control of their healthcare, to get involved. And one way of doing this is using tools like Google Health or Microsoft Health Vault. But to use these tools, you need to have access to your data. The Stimulus Act did include some requirements to share data electronically, but we need to make that a little bit stronger. We need to make sure there's no cost involved, and we need to make sure that meaningful use is tied back to this idea of being able to provide data to a personal health record system of a patient's choice. We need to work on privacy issues. There's obviously been a lot of resistance by some privacy advocates to health IT. Some of it's been legitimate, some of it I think has not been legitimate. But the focus in the United States should be on making data secure, finding ways to promote secure standards and the kind of technical controls that deliver this. The use of audit controls, the use of access for patients to the audit logs. Those are all ways to help drive these privacy requirements. But we also need a discussion about the fact that overly restrictive privacy laws do have trade-offs. I don't think there's been enough of a focus on this. And when we talk about implementing, there might be the ideal privacy law, but you have to understand what the costs are involved in that. And when we talk about how we want to design privacy in this country, we need to take those trade-offs into consideration. We need to do more to identify and eliminate some of the regulatory or smaller barriers to health IT adoption. I think there are a number of small areas where we can make progress. One example of this is making sure insurers are reimbursing patients for telemedicine to encourage adoption of these areas. We want to make sure that doctors who respond to emails get paid for this. Denmark's done a lot in this area. We need to work with the DEA to make sure that they pass regulations to allow e-prescribing of controlled substances. And we need to work to, of course, identify other barriers, and that's part of the national strategy. Medical research is really one area where I don't think enough people are talking about how health IT is really going to transform this field. We talk a lot about how it's improving quality, lowering costs, increasing access to services, but all of this data really allows you to do fundamentally new research. Health informatics is a very powerful field, but to do this well, we have very strong scientists at NIH. We have very strong programs in this regard, but what we don't have are, we don't have a strategy to take all the information that will be digitized in electronic health records and make it available in some way for medical research. And this is very different than what you see in other countries. In the United Kingdom, the NHS, in designing their electronic health record system, specifically is looking at medical research. They consider medical research part of their mission. So it's not just about improving the ability to exchange between different doctors, but setting up the data, setting up the records in such a way that facilitates this research, working with the researchers, because this is really something that benefits everyone, it benefits society. So again, this is one area where we need a national capability to share data. We need to have the regulations in place, address the privacy issues that come up. And we need to, when we're talking about meaningful use, make sure that we're considering secondary use of data and try and tie these in to these definitions for these incentive payments. And the last recommendation that we have is to do more to collaborate with all stakeholders. When we talk in this report a lot about strong government leadership, strong government involvement, this doesn't come at the expense of collaboration. This does mean working with industry. This does mean working with the providers and insurers and all the other stakeholders in healthcare. It also means forming international partnerships to keep learning from the global leaders. That's what we tried to do in this report. That's what we're trying to do now, and that's what I'm hoping our panelists will talk to us a little bit about. So with that, let me go ahead and turn it over to Hanu, and we're looking forward to hearing from you.
Oh, thank you. I was guessing a little bit in advance that because this report is so comprehensive and well built, so I have very little to add to talk about the particular IT issues. I think it's all there. But if you think then strategies, how to implement and how to make use of it is something we in Citra are very much involved in, and I would like to share a little bit broader perspective to the whole healthcare issue this morning. And I'm sure that the Danish people are particularly focused again back to IT, so I hope this will help you best. So what Citra is the Finnish Innovation Fund. We are a national fund established in 1967, and we have our own assets. We have about our endowment capital is today about $800–900 million, and we are about 100 people. So and every year we spend approximately $70 million for those projects, those issues we are doing in our country. And the law, there's a law on us. The law says Citra should ensure a better future for Finns.
So we have a nice job to do with it. So and broad perspective. We are under the supervision of the Parliament, but they don't touch us because we do things which are politically too hard. So we have absolute freedom. And therefore, this is what we have been doing healthcare now for about 5 years. I'm a director of the healthcare program, so we have been deeply involved into the Finnish system. And in the beginning, when we got started with this program, and I trust this is the way to go ahead. Yes, we have realized that we are a small country, of course, and we are spending about 8% of our gross national product to healthcare, and it's growing quicker than our GDP is growing. And our country has a problem, not the same, I mean a little bit different problem from yours, because your population, of course we are all aging, but you get all the time young blood into your country. We are, the share of people retiring during the coming 5 years is growing very quickly in Finland. And actually, in about 10 years, we don't have enough hands and heads to do all those things we should do in Finland. And also we are out of money and we are out of people. So we have to find better ways to do things. So these questions are very relevant to Finland. And the issue of IT is, of course, and technology for Sitra is very, very important because that is, of course, important for the well-being of the country. How can we enhance these things? And we have been doing this quite hectically and very, very oriented way, and we pushed about 3-4 years ago, we pushed through a law where we have now a national office in our Ministry of Health, which is actually directing the development and further cohesion in this national archive, and also later this national electronic patient and health record. So it's moving. It's not moving very quickly. It's 100% used already, but there are still limitations because there are various systems in various places in our country. So the data is not moving freely yet in all over the country. The other thing which is now coming very, very quickly is the National Health Portal, because we established a group of people. It was actually Sitra organized, that we have companies and all of the ministries who are putting together a plan for architecture, for a platform for a citizen to manage his business, is it healthcare or whatever, in an electronic environment. And we started with healthcare. So, and when we started this, we were a little bit unsure where to start, and we went because the doctors told us, don't empower the patients. We get problems if you start helping the patient too much, they make silly questions, and we don't have time for that. So that response was kind of a negative. But then the Doctors Association, Duodecim, they have a very nice decision-making tool for themselves, which they use all the time when they meet patients. And it's Cochrane database-based stuff, and it's very reliable, and it's all scientific. So they came to us and said, could we translate it to layman's language and make it available? And we said, okay, we pay if you do it. And we opened this new health portal, which is pure information on diseases and how to manage yourself in these situations. And guess what? We have 5 million people, and during the first year, without any advertisement in the public, 30 million article openings. Huge success. Everybody absorbed it. And then we realized there's no question what we should do. We should give every tool to the patient, whatever that we can help them, because they want it. They really want it. And this was very, very important for us to start pushing this personal health record issue. And we started disease management programs in the country, and it's very, very clear now that this is the way to go. And I come back to that a little bit later. But then there's another thing which I'd like to raise with you, and this is something which is something that because the healthcare is so untransparent, we understand now very well, and I think we heard already that the issue of IT is of course making everything transparent. Because if you try to manage and you can't measure, it's a problem. And the only way you can get data quickly available is, of course, electronic. And how you measure health is, of course, a big question. And that is always one excuse by the profession that there's no way you can measure health. But yes, I'm absolutely sure we can. And there are you can change many things to surrogate endpoints. You can always find ways to measure if you want to do it. And we have very strong experience on that, and we believe you can use it. And therefore, IT is very important, but it's only a tool. It is still, we have the problems of structure, which are all over the world. Every country has its own problems. We have both public and private healthcare. 25% is private, and we see how when healthcare is provided by a community which is very difficult to control if they are not made accountable in a positive way, then suddenly things start to happen, and there are all kinds of players in the field and all kinds of mediators between the payer and the real act between the doctor and the patient. And of course, the doctor has one way of looking at it, and I'm not blaming anybody, but I've seen it many times in Finland, that when there's private doctor's office, what is the best interest of the doctor first? To have his appointment book full, of course. And of course he wants to help the patients. But if I go to the doctor or a private clinic and ask, I don't want to have any visits to the patients, I don't want to have any lab tests, I only want outcomes. They can't deliver. They are absolutely puzzled, because now suddenly they should start thinking horizontally, and not only single visits and single acts. And this is something which is very, very difficult. But at the same time, if you sort things out in a different way, and you have the data available, you suddenly can start moving things. We made a trial in Finland.
We took two big companies, and we became the mediators here. We got rid of those who usually sell services to the companies, because usually there's a seller and then the provider is behind there, and the company just pays the bills. We came here and said, okay guys, we will be transparent to you, but to you payer. We tell everything, but we also then start, we buy the services from these guys, but we don't buy anymore these transactions as such. We only buy processes which end up to a healthy person, and we only pay for health. And with these two companies, we gained very quickly, with a very small investment, we gained about €1,000 per employee per year extra, and that was very, very quick return of investment. With a few million investment, tens of millions return, low-hanging fruit. So it is doable, but it's very, very tough. But you need, of course, the data. Otherwise, you can't manage. You need the data, because you have to have quality and the price. Otherwise, you can't do it. But then there is one more thing I'd like to raise with you, and it is the fact that we in healthcare, we are heroistic savers of the patients, as you know. We are taught to be doctors who save the patients from almost from death back to life. And that is, of course, we are here. And where should we be? Somewhere here. But the whole healthcare system is tuned to disease management and managing the disease. And if we think about what really this is all about, and I think this is about the right data, I would say that this is roughly right, and it's better than exactly wrong. So, but I would say that these two things are the motivators to put the patient in the center and responsible in a positive way. Because if we take healthcare system, we only can affect 10-20%, and still we spend 80% of the healthcare system's costs are in chronic disease when the patient is practically lost overall. So why are we focusing to the lost cases? I'm exaggerating, but of course this situation when we get chronically ill, the body has already used all its resources and then it gets sick. So why should we start early? And that's something we are now very much doing in Finland. we are rewriting our legislation, and I trust it's going to come out still this year. So that we first do these things, and it's important that we get the healthcare system working better, and if we get it outcome-based and transparent. But at the same time, we have to start learning to do things this way, and then the patient becomes the center, and we are taking preventive measures. And of course, we need even new people, how to train these people who actually help patients be in the center in a way that they can help themselves better. So these are my conclusions. Yes, we have a long way to go, but there are a lesson for everybody if we want to get better outcome of this, which is a very, very complicated puzzle to get things right. Thank you very much.
Thank you. Okay, we're going to now have our remote presentation straight from Denmark. And what we're going to do is after Christina and Morten present, then we're going to have a Q&A and we'll bring them up on the video so we can all have a conversation here. Christina, you can go ahead and go when you're ready.
Okay, thank you very much. I just heard you cannot see me, so I'm assuming that I cannot see you. At least I cannot, but I hope you're all sitting comfortably and ready for a presentation that will be given by me and the Managing Director of the eHealth portal, Morten Elbæk Petersen. If you continue on to the next slide, please. It's the agenda that will show you what our presentation will be about today. I'll give you, we'll tell you the general comments and report. We'll tell you a little bit about how health IT is in Denmark and how we got there, and tell you maybe perhaps what we think you can learn from us. Next slide, please. The general comments about the report is thank you. Mange tak in Danish. Can you all hear me?
Yes. Yes.
Okay, problem. I was just concerned for a while, but thank you very much for putting us among the leaders in health IT. If you go to the next slide, we were kind of expecting us to be on the top, because in 2003 we won, or 2004 in fact, we won the European eHealth Award together. The Medcom organization and the eHealth portal won the prize because we've shown that our solution was one of the best in Europe. Next slide, please. Moving on and looking at the globe, I just wanted to give you an overview of where Denmark is. You can see that it's right in Scandinavia. It's on top of Germany and south of Norway and Sweden. And the flag that's planted there is our Danish flag. Go to the next slide, you can see how many citizens we are in Denmark. We're quite a small country. We have 5.5 million citizens. We have a centrally managed healthcare system, and healthcare is provided directly by the public sector. I think you call this a single care health system. What is very unique about this in Denmark is that we have a unique person identifier, and this has helped us in our progress towards becoming one of the best in health IT. Next slide, please. Now, health IT in Denmark, the citizens of Denmark, they have access to many telemedicine solutions, telehealth solutions, Telecare solutions, and they even have access to their own patient information online. And all this can only be happening because of what Daniel Castro told you about later, because we have electronic patient records, we have the infrastructure and the standards, and a whole lot more, which I will cover in the next minutes. Next slide, please. Now, just to show you some pictures of what we have here is the telehealth solution. Here in Denmark, it's possible to receive specialist healthcare over video conferencing. That is, if you live in a small rural area, you can, over video conference, see a specialist doctor over distance, which has been shown to be very good. In fact, diabetes patients living in a small remote island in Denmark are actually better treated now because of the telemedicine solutions that we implement. What we also have here is interpretation from a distance over video conferencing. We cannot do it over a phone in Denmark, it's not allowed, but if we do it with an image as well, it is allowed, and the business case has been proven very strong. Other solutions that we have in Denmark are Telecare solutions that you can see on the next slide. What we are able to do here in Denmark are hospitalizing patients in their own home. So in this example that I've given you an image of, we have seen here that patients with smoker's lung disease, instead of being in hospital for 2 weeks, we can have them in hospital for just 1 or 2 days and then throw them back home, and through a Telecare solution, they can meet the doctor and the nurse, and in emergencies, they're even able to help them from a distance. If you go to the next slide, you can see another Telecare solution. I've just picked out a few that have very strong business cases and that are highly implemented or are going to be. The next one, Telecare, is treating patients with diabetic ulcers in their own home. Previously, what we saw was that if you had a diabetic ulcer, it was not very well treated, which led to too many amputations and too long waiting time. What we saw that if we brought out the nurse to the patient's home and via a mobile phone took a picture of the ulcer, which is sent to a specialist, the ulcer and the patient is treated much better, and there is a reduction in amputations of 40%, which was very nice here in Denmark, and I'm assuming the same case would be in the States. Moving on to the next slide, what we also have here is an e-patient. I call it the e-patient. Well, patients have access to their own information online, and Morten will give you a much better overview of what we specifically give the patients access to here in Denmark. So at the next slide, I've just put in how did we get here? How did we get there? Go to the next slide, and it says in 1940, because that's where it all began, and that's what we think has been the foundation of becoming the leaders in health IT. Remember, we got the unique personal identifier in Denmark. Well, in 1940, the first national cancer registry was established, and we're actually world famous because of this. What we did was we gave every doctor, it was just a penny back then in the 1940s, to register every time a patient died from cancer. And in that way, we've been able to track what causes the cancer. This experience, combined with the unique person identifier, has made it possible to create a lot of other registers in Denmark, and with this, digitalized healthcare in time. To move to the next slide, I'm showing you how we moved forward, because in the 1980s, hospitals, well, in fact, only the laboratories and X-ray departments, they started using digitalized analysis systems, and clinicians from other departments, they came and saw this and thought that maybe if the laboratories could use digitalized systems, computers, maybe they could as well. And what they also saw, that they went to the grocery stores and did their shopping, and what they saw was that there they used electronic systems to order other new groceries for the store. So a general practitioner, in fact, he went downstairs to where the pharmacy was, and he said to them, perhaps we can develop the same solution as they're doing in the grocery stores. And that was the first example of an electronic prescription. It was just one doctor and one pharmacy who started all this. So in 1992, you can both go to the next slide, please. There were more than 200 different IT projects in Denmark. Different people sitting around the country had all their little systems and maybe did one e-prescription, but they found out that perhaps it was a good idea, and it has proven to be a very good idea, to create one organization that pulls all the projects together and make sure that it's going to be on a nationwide scale and disseminated to everyone. So since 1992, 2 or 3 cycles of public e-health strategies have been implemented over the past years. Move to the next slide, please. The Medcom organization, just to give you a short overview, is a non-profit organization. It's established established and paid for by the authorities in healthcare, and it was established in 1992, as I said earlier. Today it runs in project periods, and we're right now in our 6th project period, and this is to make sure that the Medcom organization can follow the changes that are in IT and healthcare. And the focus is, as I said earlier, a large-scale national implementation and contribute to the development, testing, dissemination, and quality assurance of all electronic communication. If you move to the next slide, please. So today, the prime focus of Medcom, our projects focused on the use of the health data network, which you can see the image of on the picture right there. What we've done is we created a network where everyone in the healthcare sector can talk together. So you can see that the dentist, they can talk, if they need to the general practitioner. The general practitioner can talk to the pharmacy, sending electronic prescriptions. And it facilitates very much the use of electronic communication and makes sure that the people that should be talking together when they treat a patient, they are talking together. The network today is, and has been, continues to be, a very efficient tool and safe tool in the communication. What you can see at the top also is that the citizen is connected to all this and can go in and access information. But Morten Elbæk Petersen, who's sitting next to me, will just in a short while tell you more about it. If you go to the next slide. What Medcom is also famous for doing is that we've created standards for communicating between the different IT systems. And today there are more than 100 different IT systems in healthcare, and they all talk together. For example, the general practitioners, and we just have about 2,000 general practitioners practices or offices, they can choose between 14 different systems, but they know whichever system they pick and whatever system they buy, they will know that they have the Medcom approval so they can send prescriptions. And that is why today, electronic prescriptions today are 100%, because all the general practitioners have all IT systems. If you move on to the next page, just to give you an overview, or the next slide saying electronic messages 1, I'm showing you how in 1995, 1 million messages were sent, electronic messages were sent, such as prescriptions, such as referrals, reimbursements, etc. Then in 1999, we had 2 million messages. If you move to the next slide, the numbers I've given you right now, it's actually every month. In 2009, we sent 4.7 million electronic messages in healthcare every month. And this is a country with just 5.5 million citizens. So you can imagine there's a lot of communication going on, and it's a foundation for a lot more. If you go on to the next slide, we did showing you the benefits. We did a survey in 2004 looking at what were the benefits of just the electronic referral. And we saw in the 2004, we saved $1.7 million each year. Instead of using paper-based, by having it electronic, it will 1.7. Today, 88% of referrals are sent electronically, and this means a $5 million savings a year. It might not sound much in American ears, but in a small country of just 5.5 million citizens, it's quite high. I'll now give the microphone to Morten Elbæk Petersen, who'll give you an overview of what else we can offer here in Denmark, and that's the Danish e-health portal. You can move to the next slide.
Thank you very much, and thank you for including me in this session. Maybe you see a girl on the slide right now. Then if you make one more change, you will see a screen dump. And I will, during the next 5 minutes, try to introduce you to the essential parts of the Danish e-health portal. Then please, the next one. Imagine that you're a Danish adult, then you have a personal version of the internet portal at your disposal. It's called My Health. And if you go to the next one, a log-on with a free of charge public signature gives you access to a range of self-service opportunities and access to your own personal health data, such as electronic health record, medicine prescriptions, and history of previous hospital treatment dated back to the 70s. Here you can see at what hospital you have been, what diagnosis you had, and to where you were discharged. You can also sign up for an organ donation or make your life will if you are in a terminal phase of life. Next one, please. The personalized content is combined with a nationwide directory including GP clinics and data about estimated waiting times for surgery and the quality of care in every ward and in every Danish hospital, just to name a few of the services. Next slide, please. Here you see the purpose of the portal. It is to bring together relevant information from all parts of health service, to offer a shared platform of communication, and to empower patients by offering maximum insight and transparency in the healthcare sector. It also offers healthcare providers easy access to clinical information about their patients' medical history. And if you move to the next one, please. When talking about the portal, I have two important points to make. My first point is, by servicing both the citizens and the health professionals, the portal enables the two to achieve a cooperation based on the same data. This empowers the citizen and gives the health professionals better tools to improve quality in care. And until now, we have especially focused on the tools for the GPs, who in the Danish system are the gatekeepers of the whole Danish healthcare system. My second point is, by presenting the different services and types of information from different sectors and different authorities, the portal helps the users experience synergy. In this way, the collection of content is more valuable than the sum of the individual parts. Although our project and many of the basic elements date back to 2003, we still receive a great amount of interest from different places around the world. And if you move to the next slide, please. Fortunately, we also receive ever-widening interest from the public. For every day, you receive more than 7 page views on a yearly basis. It's obvious that we represent an easy way for the healthcare authorities to service the public better in a cost-effective way. Due to the fact that it is, or it was, a strategic political decision to establish the portal, we have no all-over cost-benefit analysis, and we have no specific estimates concerning the actual savings or the improved quality of care that can be attributed to the portal. But maybe that's not all that important. Because for the health service authorities, we have proved that a modest investment in infrastructure and the shared system has actually resulted in the development of services that are used across municipalities, regions, and governmental levels all over Denmark. And we have thus helped regional and local parts of the health service avoid investment in solutions that could be only used by regionally and locally instead of being full-scale nationwide solutions. And of course, there have been challenges, as also been told about, both technical and organizational, because it really is a hard job to keep the partners together and to focus on a portal which is not carrying their own logo. But summing up, we are the result of a strategic vision that led to a coordinated effort, and it's very hard for us not to consider our portal a success.
Okay, moving on to the next slide. Morten will continue on to stay here just in case you wanted to ask him questions. He'll stay here. So moving on to the lessons learned that we found were important with the national leadership, financial incentives, common infrastructure, societal and cultural factors, and of course there are many more, but I've chosen just to take those. Move on to the next slide. The national leadership has been very important. The first national e-health plan was in 1994, and formal institutions formed that could pursue the goals and commitments made by the IT strategies and plans. The formal institutions that were formed were the Medcom organization, the e-health portal, and the connected digital health in Denmark. Next slide, please. The financial incentives and the government mandate has also been very important to us. The financial incentives, as Daniel Castro also said, have shown to be an effective tool to spur our health IT adoption, and that was what we first did. Later on, when we saw that the incentives did not work, we moved on to the government mandate. And an example of this was that we told the doctors, please go and buy an IT system. We'll give you even a little funding for doing this, about $2,000. But we did give them some funding. Finally, when they didn't, not everyone had purchased it, and we were still missing about 20% of the general practitioners to buy an IT system, we put it into an agreement with them and said, if you want to be able to bill and get paid for what you do, you have to send it electronically. And suddenly, within a short time frame, all doctors had IT systems. Moving on to the next slide is the common infrastructure, which has been extremely important in the facilitation of IT in healthcare. It's good enough that you have an electronic patient record, but if you cannot talk together, it might be, you cannot get the full benefit. So in Denmark, we have the Danish Health Data Network that facilitates the electronic communication, and we have the e-health portal that helps the general practitioners as well as the patients, as Morten Elbæk Petersen just told you about. This common infrastructure also helps to lower costs and increase the interoperability that is so important. Moving on to the next slide, the cultural and societal factors are also extremely important. In Denmark, we have a very high level of technological sophistication, and this reduces the resistance by doctors to change and really helps stimulate the demand from patients. Another cultural aspect which is very important to remember is there is often a very short distance from top to bottom or from the floor to the management. So if a nurse came up with a bright idea, it might be a short distance for her to find funding for her project. Maybe back then in '92 it's changed a little, but it's still easier to call up a managing director and get someone to listen to your ideas. So take this with you. This is the next slide. Remember the strategic aspects. Strategies must always be created in collaboration between all partners in healthcare, and they should be implemented by national organizations. We say that all good things come to those who wait or take action, and Medcom has always respected that we should take action when we found some good successes we could do, and we waited when we saw a solution was not mature enough. And all the IT projects that have been implemented in Denmark have always been in the collaboration between the payers and providers. Next slide, please. Thank you very much from both of us. We have listed up some websites where you can go in and find further information, as well as our email addresses should you have any questions. Thank you.
Thank you, Christina and Morten, both for your comments. We'll go ahead and open it up for questions now. We're gonna, you're now up on the screen. I'm sorry we don't have the video so you can see the rest of us, but we can see you. You're the center of attention up there. So please, if you have any questions, just please, if you can state your name and if you have an affiliation, we'd be happy to take questions for any of the panelists or myself.
I have a question. I'm from the Methodist Hospital System in Houston, Texas. Most of you guys know here in the U.S., the biggest medical center is Houston. We have a collaboration in communicating with within our own EMR, and we're trying to expand ourselves internationally. You mentioned that the country is the size of 5.5 million people. Is that correct? Which is the size of Houston. With that, it makes it easier, of course, to put together an entire country into one healthcare. For us, we'll be trying to put one medical center into a communicating hub, a portal. We're talking about an entire nation. How are we to take their advantages that they've already implemented here in our country. How are we going to be able to do that if we have many vendors, many, we don't have a monopoly. We have to work with everybody and see who's the best that provides these services.
Right, well let Christina, if you'd like to respond on what you think we can learn, and then I'll make some comments. Could you hear the question?
Yeah, I could hear parts of it, and what I heard was you said that Houston Medical Center or the Houston area is 5.5 million citizens.
Correct.
And you had one medical center that you represented, and then I heard some.
The question is, given that the Houston population and the Houston Medical Center provides for a population size about the same as Denmark, how do you take that and grow that to the United States, which is significantly larger? How do you take the lessons that you've learned?
Yeah, I think that Daniel has stated some of the points in his report, because there is some advantage of being a big country. You have the money, you have the funding. So maybe the size of the population isn't determinant number one. Of course, it is a problem and it is a challenge, but it's not number one, I think. I think the complexity, and especially the two sectors in the United Nations, the private sector and the public sector, and they're working together, their barriers incorporating the data and so on. I think that is maybe a bigger challenge than how many people there are. If you look to, for instance, UK, it's quite a big country, but they have some common infrastructure. So I think the point is to trying to build up common infrastructure that covers all over a country. It could be number one part of the answer. Maybe just more.
No, I don't have any further to add to this one.
And, I would echo that, because that's really what we talk about. You do see certain countries, or you even see certain regions. For example, in Spain, the Andalusian region, they're about the same size as Denmark. So, at a national level, they don't necessarily have, Spain doesn't have a great health IT system, but at a regional level, they do. The problem in the United States is we have, some great regional organizations. And we have the Houston Medical Center, we have Kaiser Permanente, we have the VA system. These are kind of closed networks, and they're able to develop something great on their own. And the problem is in the United States is we've said that's our strategy, and that's not a very good strategy if you want everyone to be doing the same thing. And that's why we're talking a lot about the need to bring people together to coordinate.
Yes, I'm Paul London. I was in the Clinton administration in the Commerce Department and tried to get these computerized records, the Commerce Secretary to be interested in this because business pays for so much of it. I was over at Georgetown University Hospital on Monday or Friday, and I saw that they're now trying to, they have a computerized record. Or they're instituting one. They're trying to unite all the different records that they already have within the hospital. But I think, I bet that almost anybody in this room who has gone to a doctor in Washington, D.C., the capital of the United States, not one of these doctors that I know of has really got a computerized record. I was on the privacy task force in the Clinton administration in 1999. We had 35 people working on privacy regulations for the HIPAA, for electronic. I sort of asked one day, how many people have seen a computerized record? And not a person in the room had ever seen a computerized record. I bet you that there are quite a few people in this room who have never seen one. And I think given the political difference between the United States and Denmark or Finland, you have to get the public to understand that there's a significant, computerized records are not some abstraction. A lot of politicians have never seen a computerized record. They don't even know that there is one in Washington at the Veterans Administration. They just don't know it. So I think part of this is to educate people about what the possibilities are, not a group maybe like this, but somehow the public has to understand the differences between a paper record which fills the whole table and is unusable, and a computerized record where you see all the information that you really need on the first page. or most of the information. But I think people just have no idea what we're talking about when we talk about computerized records. As I said, the 35 people on the privacy task force had never seen a computerized record.
Please, go ahead.
I'm Marshall McLaughlin. I'm COO of a group of hospitalists in Metro DC. We're physicians that only staff hospitalized acute patients in several hospitals. Former CEO of the cardiovascular group in Northern Virginia. And it's interesting, it kind of fits in because at some of the slides saying what the US hasn't done kind of doesn't pull together commonality of definition. One example, the cardiovascular group cares for 250,000 North Virginia cardiology patients. Since 1990, every single one of those has been fully electronic. Still, the patients were hearing on the outside, well, I need a CD, I need a key fob, I need something. Now, in 1990, if you were in Florida and could get to the internet, you could securely log in and see your cardiology records here in Northern Virginia. With a prior group, I did the same thing for Northeast Cardio Associates in Bangor. 2/3 of the state of Bangor, every single cardiology patient has been fully electronic since 1990. Yet those are pockets that people don't hear out of because they just went in unless you encounter them. It was noted that you don't get paid if you aren't electronic in this country. That's been the case for the biggest payer in the US, Medicare, for a number of years now. So in fact, every single physician's office in the US that accepts Medicare has some access to a billing service that's fully computerized. And that Medicare record not only includes CPT codes and ICD-9s, it also includes standardized federal patient satisfaction surveys called HCAHPS. It includes a number of up to like 81 core measures. Did you get a beta blocker for an MI? So we're making tremendous strides toward that, but it's in areas that aren't that pulled together and made public transparent. Okay, my question is, with the billions of dollars at stake and the number of interests, what would these countries recommend of how we set standards? Not one national standard, but effective standards. An illustration was about 1990, Europe began to set DICOM, how we transfer images. And the US vendors quickly picked up on that. So by 1991, most digitalized cath labs in the US were fully DICOM compatible. Still today, if you're at Reston Hospital Center in Northern Virginia, you take your CD into Nova, they can't read it. Why? Because the images were set by standards, but not the patient identifiers. So each company has their proprietary information. So you can see a heart, you just don't know what patient it is if you go to another hospital. So that's my question. What was your experience in standards of being able to mitigate the lobbying efforts by proprietary vendors and truly create, here is a national standard of how we're going to move cardiac ECGs, how we're going to look at cath lab images, how we're going to see CT images.
Hadi, do you want to comment first, and then we'll...
Again, 5 million people. So we put together a group of experts, and actually those players who were in the field. And we put them into the same place and said, here is a little bit money for you, and now you come out. You don't get out before you have agreed to understand it. And now we are pretty well advanced.
Yeah, but as soon as I put together my docs in Maine, the guy from Houston says, no, that's not the system we've invested in.
And I'm going to piggyback on his comment. Yes, I work for the big Heart and Vascular Center, which we are an education institution, joined with Cornell University. It's a big thing that, of course, he's right about, if we use a system, they come with a CD, and we want to just view the DICOM images. We have to use multiple computers with multiple softwares just to view 3 different images, just to make sure one of them is a heart, the other one is, you could see a 3D version of the images, and then we have to come down and create it out of those images, create our own 3-dimensional images to be able to see the system. in the hospital decided, okay, well, they're saying there's multiple systems, multiple companies, and it goes back to the question I had. We have multiple vendors here in the U.S. You're talking about two countries that already have universal health care. They have mandates by the government, and we are our own and still our own healthcare entity, but with millions of people providing, because they say, well, this product is better than his product.
Mm-hmm.
How are we going to standardize that to be able to communicate? For me to send information to Virginia, or send it to California, or send it to Cleveland,
Right.
or Mayo Clinic, which are some of the major entities in the U.S. in healthcare.
Christina, would you like to comment a little bit about the MedCom standard setting?
Sure, I would. Of course, I think it's a very big issue is what do we do about the standards? Here in Denmark in 1992, it was decided that the MedCom organization should create the standards. How did we do this? First of all, this is a small country, and back then we didn't have as many, but today we have 100 different IT systems. When we're creating a new standard, we first go out and ask the hospitals and find out what do they want in the standard. Let's take the e-prescription. It's simple. Everyone knows what it has. So we ask the doctors, what would you like in the e-prescription? We ask the pharmacy, what would you like in the e-prescription? From there on, we took, as Finland, I think you said you took all the IT experts and threw them into a room. What we did, we took a representative from each IT system, or at least the ones that wanted to work with us. We threw them into a room, we locked the door with a key almost, and we said, now agree to one standard. And they did. So they would sit there and develop a new standard. And once they would go back home to their own organizations and work on it harder and work on different versions. And in the end, we'll have a final version that was sent out to all the IT system providers. And we give the standards away for free. So once we've created it here in collaboration with the IT system suppliers, we give it away, and it's all documented on the MedCom website. So they know that if a new IT system supplier comes to Denmark, they know that they have to use the MedCom standards, and they just go to the website and they can create the standards. And I think that could be one solution, is to agree on one organization that should do this. But it's easier, of course, since we're the size of Houston, and we might have a little less IT system suppliers.
Sorry to interrupt, but we already have a solution like that. It's called CCHIT, which is, it's everybody's standardizing. If they're not certified by that system, it's standardized, but we still have multiple vendors that meet the standard by CCHIT, but they have their own system, their own programs to view this system. So
okay, but see, you're not allowed to send anything on the health data network if you're not using the MedCom standards. So it's pretty clear that we, you could say we own the market even though we're not earning anything on it. But what with the standards that we're using, or if you're talking about programming, it's, we started with EDFACT, which is an old standard from the 70s or 80s, I think. And now we moved on to XML. If you were talking about bringing portals together, it's something called suites. And we're using info brokers to have DICOM systems communicate together.
And I think it would be critical, just one statement for ITIF, to strongly support that the high-tech stimulus funding for RIOs and health information exchanges, their very first goal ought to be to establish the standard. Exactly what she said. Nothing moves through the pipeline that taxpayer dollars have paid for, so the vendors can make more money, unless they agree to a standard that can be picked up, maybe not operate at the other end, but interoperability from I can access the data and it's in my database.
Mm-hmm. I think that's what
Otherwise, we're just
is.
paying money for vendors to increase their profit margin.
In the back, go ahead.
Hi, I'm Lauren J. McCarthy, an associate at Corpus Communications, a fully integrated communications firm here in DC. One of the things I'd be interested in is how did you get the patients to buy into these telehealth and telecare models? I think now there's a lot of conversation about
Do you want to come
quality.
up to the microphone?
Good morning. I'm Lauren McCarthy. I'm an associate at Corpus Communications, a fully integrated firm in downtown DC. One of the questions I had was, how did you get the patients to buy into these telehealth and telecare models, with the conversation today being around quality healthcare, face-to-face time with the physician? What kind of tactics were used to kind of get the patients to buy into that?
Is this a question to Denmark or?
Yes, to Denmark.
Okay, what we actually found, but maybe you can also answer this, is that, for example, the solution with the Telecare solution, where the patient is sitting at home, they found that they had a much better communication with the doctor because of the systems. That when they're sitting in front of the computer screen and saw the doctor on the screen, they had much better communication. Would you want to say?
Yes. I think in Denmark we have a very good story about net banking. The last 10 years net banking has been dismissed in Denmark, and every adult in Denmark is using net banking. So we just have to say that the e-health portal is something like net banking, but on the healthcare system. Also, it's more easy if you want to see your GP. Instead of hanging in the telephone line for hours in the morning, you can just make an email when you want to, and not only in the opening hours for 1 hour in the morning when you never get through. So there's so many ways you can have more time for yourself instead of being in hanging in a telephone line. So there's a lot of advantage for the public to use those solutions, I think.
I know we started a little bit late, so we're going to end just in about 5 minutes. Let's take maybe 3 more questions.
Oh, good afternoon. I'm Dr. Schaefer from Marymount University, and a question for Denmark and Finland. Where is IT in the curriculums for the medical schools for training doctors, or the nursing schools for training nurses?
We'll start with Finland.
I think it's excuse me?
That's okay. We'll start. Is that okay?
Oh, go ahead.
I think it's very low in the education, but it's very high in the general agreements. You only get fee if you do what the agreement says that you should do, and you should, for instance, make email consultations and not see the patients. So it's incentives that we are using afterwards. But of course, in the future, we have to incorporate all those things in the education. Of course we have.
We are very fortunate that we have a high degree of internet usage. So all the doctors that go to the universities, they now have computers and use it. So we do know that the next generation of general practitioners and doctors and specialists coming out, they will be demanding to use IT systems every day, all the time. But otherwise, we have, as such, we do not have it, but we talked about putting it on the curriculum. But so far it's worked. Moving on to Finland.
Okay, it's basically the same as in Denmark, so that there's no particular IT curriculum in their programs. But as an example, for instance, what we did a few years ago, we introduced this triage management in our country, and the nurses and those people who became involved, they have no experience whatsoever how to manage this kind of things, because we wanted these people to become part of the healthcare system in a way that they could open also APRs and look at, okay, what's your problem, and start kind of planning your care immediately, so that you don't go unnecessarily to see a doctor, but if you need a doctor, you definitely get the doctor immediately or a nurse immediately. So this kind of way of using IT in a new way and a creative and good way, we organized then nursing schools to start educational courses. So there's a specialist stuff nowadays for nurses. If they want to go this direction, it's possible.
Thank you. I'm Arlene Poland, Technology Policy Institute. You referred to privacy issues in the U.S. And indeed some of that privacy efforts are holding up progress toward more health IT adoption. I'm wondering about the unique identifier, and through what means would the speakers think that we could, or you think we could get there? Would it require, I mean, can a national health identifier an individual one be adopted through the current processes for adopting certification and meaningful use standards? Do we need legislation? How is that going to happen in the U.S.?
Well, as I mentioned earlier, it was part of the HIPAA legislation, and
it was defeated.
And it was right, and it's been defeated. My understanding is every year there's an amendment added to this specific requirement. We do have national identifiers for providers, so we do have a system in place for that. I mean, that's how you do billing.
Right.
And as we said, that's one of the areas where the U.S. has had a lot of success. So it's really a matter of just saying, yes, we are going to do it now, and we do need to come up with a standard for it, and there's different ways now we can learn from other countries about how we want to do this. This gets to a kind of a bigger issue of electronic identification. We're actually going to be doing a report on this in a few months, because you do want electronic identification for a number of different IT systems. So maybe this is something that we want to think about at a broader level. You do have a lot of countries, though, in Europe, France implementing a large-scale system of smart cards for patient identifiers. But even in the United States, we don't even have a system of electronically readable cards right now. And that's just sad that you can't even in the private sector just go into the doctor and easily identify yourself with a card that you can swipe. So we're making slow progress in that area. Part of that, I think we're seeing private companies come together and say, if the government's not going to do it, we're going to do it. Finland?
I'd like to see it. Can I see it?
Yeah, sure. I have also one. Can I
Sure.
also ask a question from the participants and also from Denmark, because Denmark is well advanced and there are, as you told, nice pockets or nice entities in the country. Are you already using this data which you are now collecting? Actually, there's a lot of data available. Are you using it also for actually outcome measurement and kind of ability recognition and guidance for next steps, how to make things better?
As Methodist Hospital is one of the top hospitals in the nation.
Right.
Of course, we have come out of the top entities, the best hospital